Module 5. Let's talk a little bit about electrocardiograms. An electrocardiogram is abbreviated ECG or EKG. If you've ever heard of an EEG, that is an electroencephalogram, which is a record of the electrical activity in the brain. When you're dealing with an electrocardiogram, you're looking at a record of the action potentials produced by cardiac muscle fibers during a heartbeat. There are many different uses for an electrocardiogram. You can use it to detect abnormalities in the conduction system. You can detect enlarged heart chambers. You can detect regions of heart damage. You could determine the cause of chest pain. You can even detect electrolyte and hormonal imbalances. Now, the tool that is used to create this electrocardiogram is an electrocardiograph. And there are many different kinds, some giving more information, some giving less information. We're going to take a look at an electrocardiogram and sort of hit the basics, something that if you're heading into our nursing program, you've got information to support further study and use. Now let's take a look at an actual electrocardiogram. At the top of the screen, you will see what looks to be a grid going from left to right. This grid is supposed to represent the appearance of electrocardiograph paper, or what you would see going across your computer screen if you're doing a computerized record of your action potentials. Now, each collection of electrical changes that you see going across the screen represents the electrical changes during one cardiac cycle. So if you were to count the changes going across the screen, you can see that there are 5 individual cardiac cycles being represented across this grid. Now, what this allows you to do clinically is if you were to record, let's say, the cardiac cycles occurring during a 1-minute interval, you can actually count how many individual cardiac cycles your patient went through in a 1-minute period of time. You can also calculate the time it takes to go from one cardiac cycle to the next. Now, if you were to take one cardiac cycle and look at the specific electrical changes that occur, this is where you have a lot of clinical significance. So at the bottom of the screen, we have 2 cardiac cycles being represented. We're going to start on the left, and then we'll be going to the right, and then back to the left, and then over to the right. So if you look at the right-hand image, you can see that there are 3 major components to an ECG. You have the P wave, the QRS complex, and the T wave. Now, the P wave is when you have atrial depolarization. So that means that the cardiac muscle cells within the atria are being electrically stimulated to depolarize. Now, this is going to occur because the sinoatrial node has released an action potential. It's traveling through the internodal pathway, stimulating the cardiac muscle cells in the right atrium. It's traveling through that interatrial bundle and through its fibers that are extending out through the left atrium. And all of that muscle is getting stimulated. Now, as you learned in A&P1, electrical stimulation triggers contraction. So on the right-hand side, you can see something called the PQ segment. The PQ segment is when your atria actually contract. So this is when they're going to undergo their contraction time. Heading back to the left, you can see that the PQ segment is then followed by a huge electrical change called the QRS complex. The QRS complex is rapid ventricular depolarization. So this is the period of time when that subendocardiac conducting network is carrying the action potential through the ventricular cardiac muscle cells from apex towards base. So we're stimulating your ventricles. If you stimulate during the QRS complex, the ST segment, which follows, is when your ventricles are going to contract. So if you kind of look at the pattern here, we have the P wave where we depolarize the atrial muscle, followed by atrial contraction. We then have the QRS complex where we depolarize ventricular muscle, and then that's followed by ventricular contraction. Then we have this last little peak. It's called the T wave. The T wave is actually the electrical changes that occur during ventricular repolarization. Recall from A&P1 that whenever you're performing an action potential, you have that depolarization phase, but then you also have to follow it by repolarization, that return to your resting membrane potential. And cardiac muscle cells do have to repolarize to their resting state in order to be stimulated again during the next cardiac cycle. Now, repolarization, the return to rest, always signals that your ventricles, the muscle cells, are going to relax. So following the T wave, that large flat span between the T wave and the beginning of the P, all the way to the next Q. That entire period of time is actually ventricular relaxation. Your ventricles have repolarized, and it's not until they undergo the next QRS complex that they'll contract again. The only thing that you can't see on an ECG is atrial repolarization. You can see the atria depolarize with the P wave, and you can see where they contract with the PQ segment. However, they repolarize during the QRS complex. And because the QRS complex is such a strong electrical change, because it's occurring in those massive ventricles, you're unable to see the atrial repolarization. But no, your atria do repolarize during the QRS complex, meaning from the end of the QRS complex all the way through the next P wave, your atria are relaxed. The muscle fibers have returned to their resting membrane potential. They are completely relaxed and waiting for the next electrical stimulation during the next P wave. So this is sort of a colorized version now of everything that you just did. So in the top left corner, you can see the P wave, the spread of the electrical signal through the atria. You can see in the image below it the P wave completing. And then as you go through the PQ segment, your atria contract in that little second image. During the QRS complex, you can see the green, the atria repolarizing, but you can see with the red, the ventricles starting to depolarize. That leads us to the top of the next screen, the next column, where you have your ST segment. You've got that nice depolarized ventricular muscle, and you can even see the ventricles are contracted. As you go through the T wave, you can see the green repolarization starting to spread from apex towards base. And after the ventricular muscle has repolarized, the ventricular muscle relaxes. The action potential that begins at the sinoatrial node and then spreads throughout the entire heart is going to excite your contractile cells. And the contractile cells have some similarities to the skeletal muscle fibers you learned about in A&P1. The action potential is going to lead to an increase in calcium around the myofibrils within the cell. That calcium is going to bind to troponin complex, which is going to permit the contraction cycle to function and the cells undergo physical contraction. Because of the similarities in that mechanism, we're not going to redo that mechanism in A&P2. We're going to assume that you remember. What is different is the actual action potential itself in the cardiac muscle cell. Now, what we have here on the screen, this is from your lecture textbook. It is a beautiful two-dimensional drawing showing in green the action potential and the repolarization back to the resting membrane potential, and in red the muscle contraction that occurs as a result. And the steps are nicely written on the side. Now, I could teach the entire action potential using just that image. However, this and just staring at it does not address visual learning, believe it or not. It does not address hands-on learning. And I've discovered most of my students tend to be visual and hands-on. So what I prefer to do is to show you an alternative way to review the material that is more visual, more hands-on, and it's something that you can do to review if you don't have a computer handy and you can't pop open this recording and see it if you don't have something else available. So here's where we're going to start. What we have on this screen is one resting cardiac muscle cell. Now, the line going across the center is the plasma membrane of your cardiac muscle cell. Above the line, you have your extracellular fluid, where, as you learned in A&P1, you have high levels of sodium and calcium, but very low levels of potassium. Below the line is the intracellular fluid, the fluid within the cell, where you have very low levels of sodium and calcium and very high levels of potassium. Okay, that's review. Now, in the action potential for a neuron and a skeletal muscle fiber in A&P1, you learned that there were two ion channels involved, voltage-gated sodium and voltage-gated potassium. And those two ion channels are present in your cardiac muscle cell plasma membrane. The voltage-gated sodium is in black on the left, the voltage-gated potassium is in blue on the right. However, there is a third channel involved in the creation of your cardiac muscle cell action potential, and that is voltage-gated calcium, which is in red in the center. Now, at rest, these channels are all closed, which is why there's that little oval stopper kind of in the middle of the channel. You also need to remember that there is that little sodium-potassium pump always at work in the plasma membrane. So remember, this pump is working when the muscle cell is at rest. It's also functioning when the muscle cell is active. And its job is to move sodium from the intracellular fluid out into the extracellular fluid, and then it moves potassium that happens to be in the extracellular fluid and brings it in to the intracellular fluid. So this little pump just runs 24 hours a day, 7 days a week, never stops. The other thing that you need to know is that the resting membrane potential in a cardiac muscle cell is minus 90 millivolts. Now that is different from last semester. Last semester you learned that the resting membrane potential of a neuron is minus 70 millivolts. Skeletal muscle fibers, for comparison, are minus 85 millivolts. So different cells have different resting membrane potentials. So this is where we start. All right, this is where we start. Now imagine that you are a cardiac muscle cell. Let's just pick right atrium for the sake of argument. Okay, so we are one little cardiac muscle cell in your right atrium. And that cardiac muscle cell receives an action potential coming from the sinoatrial node passing through the internodal pathway. That action potential is going to stimulate your plasma membrane and cause it to depolarize from minus 90 millivolts to minus 75 millivolts, which is the threshold voltage for your cardiac muscle cell. Right? So the action potential that originated at the SA node is going to cause the plasma membrane of your cardiac muscle cell to go from minus 90 millivolts to minus 75 millivolts, your threshold. The arrival at threshold is going to cause your voltage-gated sodium channels to open. Now, remember, ion channels are just basically little tunnels through the plasma membrane. So you start opening thousands of these little voltage-gated sodium channels, and all of a sudden sodium is free to move from high to low by diffusion. So sodium is going to move from where it is high in the extracellular fluid. It's going to pass down through that channel to the low in the intracellular fluid. Now you need to remember that sodium has a positive electrical charge. And if you start adding positive sodium ions to a negative interior, you're going to start to make that interior less negative. In fact, you're going to have such a rapid inflow of sodium that you're going to depolarize quite quickly to positive 30 millivolts. You're going to have a complete reversal of your membrane potential. So this is now your action potential. Now, once you get to positive 30 millivolts, your voltage-gated sodium channels close and the sodium inflow ceases. Now, at this point, with what you learned in A&P1, your neuron or your skeletal muscle cell would immediately begin repolarization back to resting. But that is not what happens here. After you depolarize to positive 30 millivolts, you are going to enter a new phase, which is not present in the action potential of neurons or skeletal muscle fibers. You are going to enter what is called plateau. Plateau is a period of maintained depolarization. So you're going to repolarize a little bit. You're going to go from positive 30 millivolts. Your voltage is going to decline, and then it's going to get to 0 millivolts. And you're actually going to hold the membrane potential at 0 millivolts for about 200 to 250 milliseconds. That is a huge period of time to be depolarized. Right? 0 millivolts is still depolarized. You are more positive than you are at rest. Now, in comparison, neurons and skeletal muscle fibers, they are only depolarized for about 2 milliseconds. So the addition of this plateau is allowing your cardiac muscle cell to stay depolarized for a significant period of time. Now, the creation of plateau is actually due to the opening of the voltage-gated slow calcium channels. So this unique third ion channel you don't have in neurons and skeletal muscle fibers is creating this unique step. And what happens is the voltage-gated calcium channel is going to open. Calcium is going to move by diffusion from the extracellular fluid where it is high to the intracellular fluid where it is low. And this calcium influx actually causes more calcium to be released from the sarcoplasmic reticulum. Now, this has a lot of significance. The inward flow of calcium, because of these unique channels, binds to calcium channels on the sarcoplasmic reticulum. This opens the calcium channels in the sarcoplasmic reticulum, allowing this organelle to release larger amounts of calcium into the cytosol than in skeletal muscle fibers. So you're going to have more calcium flooding out around the myofibrils. And what this is going to do is it's going to allow you to trigger a much more intense contraction. So you're going to increase the contraction strength because you just have more calcium available to bind to that troponin complex. Also, think about the period of time. You stay depolarized for 200 to 250 milliseconds. The extended depolarization time actually allows for a longer period of contraction as well. And this longer period of contraction is needed for you to build up the force necessary to move blood out of the heart and throughout the entire body. So this plateau phase is going to allow you to have stronger and longer contraction time to accommodate what the heart actually has to do as it's part of the cardiovascular system. Now, there are the potential causes for plateau and why it lasts so long are very highly debated. One potential cause is that the calcium influx is actually balancing out the sodium active transport outward. So remember, you've got this little sodium-potassium pump, and its job is to move potassium into the cell and sodium out of the cell. And you learned in A&P 1 that this little pump is really important after you have created an action potential, because it's going to take the sodium that moved into the cell and start moving the sodium back out, and it helps you to regain your resting membrane potential. That little pump is working here. So you do this great depolarization to positive 30, the voltage-gated sodium channels close, and this little pump is at work trying to move those positive sodiums out. And if you are losing positive charge, the interior starts to become more negative. We don't want that in cardiac muscle cells. We want to maintain depolarization. So by opening the voltage-gated calcium channel, as a positive sodium leaves, a positive calcium comes in to take its place. So it's going to offset the loss of positive charge. One theory. It's also possible that the calcium channels in the sarcoplasmic reticulum, the ones that we just opened, thanks to the calcium coming in through the voltage-gated calcium channels, they just might be slow to close. So once you open the calcium channels in the sarcoplasmic reticulum, they stay open longer. It allows calcium to be released longer, and that's going to allow you to maintain that contraction and depolarization longer. Another possibility. It's also possible that the sarcoplasmic reticulum is very slow to remove calcium from the cytosol. So once you have triggered contraction and you want to relax the muscle fiber, it is the sarcoplasmic reticulum that has to basically suck the calcium back into storage so that contraction ends. Well, if the sarcoplasmic reticulum is slow to remove the calcium, the contraction apparatus can stay contracted for a longer period of time. So there is a lot of debate over exactly what the cause is, and it could be any one of those three, it could be all of those three, or it could be none. And with new technology in a year or so, they could find something else. So there are things in the human body that we don't know for sure, and this is one of them. So we have possibilities. Now, at the end of plateau, we do have to return to our resting membrane potential, and that is where we are going to now go into repolarization. So at the end of plateau, the voltage-gated calcium channels close, so there's no more influx of calcium, and the voltage-gated potassium channels open, and just as you learned last semester, we start having large amounts of potassium moving from inside the cell out. So we're losing positive charge to the exterior. We have got sodium ions being pumped out thanks to our little sodium-potassium pump. So we're losing a lot of positive charge, especially thanks to the potassium outflow. And this is going to help drop our membrane potential back down to our resting voltage. So we are going to repolarize from that 0 millivolts back down to minus 90 millivolts. So in thinking about those three steps, looking at the green line now on this two-dimensional figure, you can see that rapid depolarization to positive 30 with number 3, but then you can see that plateau phase that maintained depolarization at around 0 millivolts for that 200 to 250 milliseconds, followed then by number 5, the return to your minus 90 resting membrane potential, and that this extended depolarization allows for your contraction time to be longer, and it also allows for it to be stronger. Now, since cardiac muscle is muscle, it's going to need to produce ATP in order to support contraction. Now, cardiac muscle cells almost exclusively use aerobic respiration, which means they're not prone to fatigue as if they were using anaerobic respiration. So cardiac muscle cells are fatigue resistant. Now, if you think about aerobic respiration and what you learned in A&P1, aerobic respiration requires oxygen. So where does that come from? Well, oxygen is going to be delivered through blood flow. So we're going to be using our coronary circulation, all the different arteries that you're learning about in lab, plus arteries that you're not required to know for our A&P2 lab. So we've got extensive blood flow bringing oxygen. Your cardiac muscle cells also are very rich in myoglobin. Remember from A&P1, myoglobin is very similar to hemoglobin in that it's a pigmented molecule, and its purpose is to bind and store oxygen inside the cardiac muscle cells. So when those cells are contracting at a high rate, if for some reason coronary circulation is not sufficient at first to get the oxygen to the cells do have their own backup supply of oxygen that can keep them going in an interim. Now you also need an organelle. The organelle that is used is your mitochondria. And if you were looking at all the mitochondria inside the cardiac muscle cell, you have so many that they make up about 25% of the cell's internal contents. So you've got a lot of mitochondria. That should just be telling you about how much ATP is actually being produced. Now, your cardiac muscle cells are also very rich in glycogen, so these cells do have glucose storage, which kind of like the myoglobin, it's that backup if we need to produce ATP and we need a fuel source and coronary circulation hasn't gotten what we need there yet, you can pull on your own glycogen to get glucose. Now, the primary energy sources for cardiac muscle cells are fatty acids and glucose. And the percentages are not what you think. Believe it or not, your cardiac muscle cells use fatty acids for approximately 60% of their ATP. So your cardiac muscle cells actually prefer to use fatty acids to get their ATP. And that's because you can get more ATP from a fatty acid than you can from glucose. So you need to get a lot of ATP, you need the best fuel source for it. Now glucose is used. Glucose is used for about 35% of the ATP production. The remaining 5% of the ATP production is ATP produced from fuel sources like amino acids, ketones, lactic acid. But if you think about, who is the primary source, it's not glucose. Like your skeletal muscle and your neuron, it's fatty acids. Now let's talk about the full cardiac cycle. We're going to talk about all of the events that occur in one heartbeat. Now the cardiac cycle is going to involve the alternating contraction and relaxation of your heart chambers with the goal of forcing blood from areas of high pressure to areas of low pressure. So blood is always going to move from high to low. In fact, have you ever noticed that everything sounds like diffusion? We've got blood moving from high pressure to low pressure. You've got ions moving from high concentration to low concentration. Get used to it. So we're going to have blood moving from high pressure to low pressure. And you need to remember that contraction is going to create high pressure. Right? So whether or not you are relaxed or contracted is going to influence your pressure. You also need to be familiar with two terms. Systole is the appropriate term for describing the contraction of a chamber. So I'm not going to be saying atrial contraction, I'll be saying atrial systole. And remember, contraction causes high pressure. So systole is going to cause the creation of high pressure. Diastole is relaxation of a chamber. So I won't be saying atrial relaxation, I'll be saying atrial diastole. Now, if contraction causes high pressure, relaxation creates lower pressure. So diastole is going to cause pressure within that chamber to decrease. Now, the cardiac cycle is a loop. So there's no start, there's no end. It's a continuous loop, a continuous cycle. So as an instructor, I'm faced with the task of figuring out where to jump in. So we're going to jump in with ventricular filling. So we're going to start here, and during ventricular filling, your ventricles are in diastole, and at the beginning of ventricular filling, so are your atria. So during the first two parts, 1A and 1B, your atria and ventricles all relaxed. Now, during ventricular diastole, you need to be aware of what's happening with your heart valves. The atrioventricular valves are open, the semilunar valves are closed. Now, the entire ventricular filling phase is divided into three smaller phases. The first is called rapid ventricular filling. During rapid ventricular filling, blood moves from the atrium into the ventricle very quickly due to the large pressure difference that you have between the chambers. Your atria have really high pressure at this point because they have filled with such large volumes of blood from the two venae cavae and the pulmonary veins. So because of the atria being a really high and your ventricles being a really low, blood moves from high to low very quickly. After you've had some blood volume moving, things are going to slow down a bit and you're going to transition into diastasis. Now, during diastasis, you still have blood moving from the atria into the ventricles, but the blood is moving more slowly because the pressure difference between the atria and ventricles is lower. The third phase of ventricular filling is called atrial systole. During this phase, the atria are going to contract, and when they do, they're going to push about another 40 milliliters of blood down into your ventricles. Now, at the end of ventricular filling, your ventricles are going to contain something called end diastolic volume, or EDV. End diastolic volume is the volume in the ventricles at the end of ventricular filling. So it's the total amount you can get into those ventricles at the end of this ventricular filling phase. And on average, it's 130 milliliters in each ventricle. Okay? It's 130 milliliters in each ventricle. Now think about that term, end diastolic. If you think about what that means, it means we are at the end of ventricular diastole. We are at the end of the ventricular relaxation. Now, from ventricular filling, we're going to transition into isovolumetric contraction. Now, at this point, your atria have repolarized, they are completely relaxed, and they're going to remain in diastole for the rest of the cardiac cycle. So I'm not going to mention them again until we get back to the beginning. So at this time, consider your atria as just being relaxed, and that blood is flowing into them, they're starting to fill in preparation for the next cycle. This phase, isovolumetric contraction, is all about the ventricles, because your ventricles are going to become depolarized at the beginning of this phase. And when they depolarize, they're going to begin to contract. And as they contract, they're going to start to increase pressure. Now, remember, when your ventricles contract, they contract from apex towards base. And as they're contracting from apex towards base, the blood is being pushed at a higher pressure superiorly. So they're being pushed up towards the valves. And what this is going to do is it's going to force the AV valves to close. Because remember, you don't want backflow. You want blood to go from atria to ventricle. If your ventricles are contracting, the first thing you have to do is close the doors so that blood cannot backflow into the atria. However, your semilunar valves are still closed. So they do not open yet. And the reason for that is that the pressure that you're building in the ventricle is not greater than the pressure in the blood vessels. So your aortic pressure at this point is 80 millimeters of mercury. Your pulmonary trunk pressure is about 10 millimeters of mercury. In order to open the semilunar valve, the left ventricle has to have greater pressure than 80 millimeters of mercury. The pulmonary trunk pressure has to be greater than 10 millimeters of mercury. And even though we are contracting, we do not have enough pressure yet to open the semilunar valves. Can't do it. Now, there is a lot of information in that name, isovolumetric contraction. Isovolume, which is the first part of the term, means that the volume in your ventricles does not change. Now think about what I just talked about with those valves. We had enough pressure to close the atrioventricular valves. So blood did not leave from ventricle to atrium. But did we open the semilunar valves? And the answer is no. So we have 130 milliliters in each ventricle. Pressure has increased thanks to contraction, but none of that volume has been able to leave. So that's where isovolume comes in. The other term hidden in there is isometric contraction. Now back in A&P 1, you learned about isotonic contraction and isometric contraction. In isometric contraction, the muscle fibers do contract and create tension, but the muscle fibers do not change in length. They don't shorten. So isometric contraction at this point is pressing on the blood. It is starting to increase the pressure of the blood in those chambers, but because the fibers don't shorten, you don't get the pressure you need in order to open the semilunar valves. Now, once we have accomplished isovolumetric contraction, we've closed the AV valves, we're going to transition into ventricular ejection. During ventricular ejection, ventricle pressure is going to continue to increase. And that's because the cardiac muscle cells change from isometric contraction to isotonic contraction. So not only are the fibers now creating tension, but the muscle fibers are shortening also. And that's going to significantly increase the pressure within those chambers. In fact, the pressure in the left ventricle increases to about 120 millimeters of mercury, and the pressure in the right ventricle increases to about 25 millimeters of mercury. So with the left ventricle now at a higher pressure than the aorta, and the right ventricle now at a higher pressure than the pulmonary trunk, that huge surge of pressure can force open the semilunar valves, and it allows for blood to leave the heart. Now, ejection does occur in two phases. The first is rapid ejection, and that's basically blood just kind of bursting at a really high rate of speed up through that semilunar valve due to the really high pressure difference between the ventricles and the vessels. Now, after that initial surge of blood leaves, you transition into what is called reduced ejection. During reduced ejection, you still have blood moving from ventricle into vessel, so you still are ejecting, but the blood is starting to move a little more slowly because the pressure difference between the two areas is becoming less. Now, the volume of blood actually ejected into the pulmonary trunk and into the aorta is called the stroke volume. So the amount that you actually eject is called stroke volume. And it's usually about 54% of the end diastolic volume. So it's roughly about 70 milliliters. So during ventricular ejection, you're taking 70 milliliters from your ventricles and shoving it up through the semilunar valves and into the vessels. Now, the 54% in the ventricle that does leave is called the ejection fraction. So your stroke volume is the ejection fraction in the ventricle. It's just that 54% that you know you are going to be able to eject during that one cardiac cycle. But here's the question for you. Are the ventricles empty? And that's where you need to think back to your ventricular filling. What was your end diastolic volume? Your end diastolic volume, on average, is 130 millivolts. During ventricular ejection, you're ejecting, on average, 70 millivolts. So that means your ventricles, at the end of their ejection, still have blood in them. They still have about 60 milliliters still lingering in there. And that volume has a name. It is called end systolic volume, or ESV. So if you think about the name end systolic, this is the volume of blood left in the ventricles at the end of their systole. So after they have given their most powerful contraction, it's just what's left. Now, once ventricular ejection is over and that contraction period is done, the muscles of your ventricles are going to have to relax. So our last phase in the cardiac cycle is called isovolumetric relaxation. So if you think about that term, isovolume means that the volume in the ventricles is not going to change. It also means that your ventricles are going to start to relax, because in ventricular ejection, we underwent isotonic contraction. At the beginning of this phase, your ventricles are going to start entering diastole, and they're going to change from isotonic contraction to isometric contraction. So that means the muscle fibers are going to go from shortened back to their longer length. So our tension in the walls of the ventricle is going to start to decrease. And your chambers are going to start relaxing, they're going to start expanding. And since we're going from isotonic to isometric, ventricular pressure is going to start to decrease. And what's going to happen is that the ventricular pressure is going to drop below your vessel pressure. So your blood vessels are going to become the source of high pressure. Your ventricles now comparatively are a source of lower pressure. Now, based on how blood likes to move, blood in the pulmonary trunk is going to want to flow back into your right ventricle. Blood in the aorta is going to want to go back into your left ventricle. We don't want backflow. So as blood attempts to backflow, the semilunar valves are going to close. However, your ventricles have still not completely relaxed. They are still undergoing isometric contraction. So they still have pressure, which is why the atrioventricular valves are still closed. Now, from isovolumetric relaxation, we go all the way back to ventricular filling, where your ventricles are now in complete diastole, allowing the atrioventricular valves to finally open and begin our next round of ventricular filling. Now, doctors and nurses can actually use auscultation and hear your cardiac cycle. Auscultation involves listening to heart sounds with a stethoscope. So the next time a doctor or nurse comes at you, they've got that stethoscope in their ears, they're actually listening to your cardiac cycle. Now, your heart does make 4 sounds during a cardiac cycle. However, only sounds 1 and 2 are loud enough for you to hear with a stethoscope. S1 is called the lub, and S2 is called the dup. So if you think about lub dup, lub dup, lub dup, and think about that sound that you might have heard just putting your ear against someone's chest, or if you've actually used a stethoscope and you've listened, you hear that lub dub, lub dub, lub dub sound. Now the lub is actually produced by the atrioventricular valves when they close. So if you hear the lub, you know that your ventricles have begun isovolumetric contraction. So they have begun their contraction phase. The dup is the sound your semilunar valves make when they close. Now, you just learned from the cardiac cycle that the semilunar valves close when your ventricles enter their diastole with isovolumetric relaxation. So by listening to those 2 sounds, you know that your patient's heart with the dup has begun ventricular contraction, and with the dup has begun ventricular relaxation. So you know exactly where your patient is in their cardiac cycle. Now S3 and S4, again, these you can't hear with a stethoscope, but they are sounds created by blood movement through the different valves. Now, occasionally you might hear something abnormal with a stethoscope during your cardiac cycle, and these abnormal sounds are called heart murmurs. And they do sound like a little bit of like a rushing or gurgling sound, and they're caused by leaky valves that are allowing backflow. And we actually mentioned the most common heart murmur, the mitral valve prolapse, earlier in our first module on this chapter. Now, with regards to timing, when you hear the heart murmur, actually gives you a good indication as to which type of valve is having the leakage. If you hear the murmur between S1 and S2, you know that you've got leakage in an atrioventricular valve. If you hear the heart murmur after S2, which is when your semilunars close, you know that you have leakage through a semilunar valve. And then also based upon where you have the stethoscope against the thoracic cavity wall, you can determine even which atrioventricular valve or which semilunar valve that you're actually having the leakage through.